Welcome back, everyone, to the scenario we've all faced, right? You're looking at a freshly printed ECG strip, and boom, you spot the T wave right there on the paper. But honestly, spotting it is only half the battle. Do you actually know what it's trying to tell you? Like, what does it mean when its shape shifts by just a single millimeter? Or what happens when it flips entirely upside down? Okay, here is our diagnostic roadmap for today. 1. The normal T wave. 2. A quick overview of T wave abnormalities. 3. Peaked and hyperacute variants. 4. The inverted T wave. 5. Myocardial ischemia and infarction. And 6. Bundle branch blocks. Part 1. The normal T wave, establishing the baseline. To start, let's look at the electrical mechanics at play here. The T wave is that positive deflection occurring immediately after the QRS complex. You can kind of think of the T wave as the drama queen of the ECG. It's incredibly sensitive and is very often the very first thing to react when the heart's electrical engine misfires. Physiologically, this wave represents ventricular repolarization, that absolutely crucial moment when the heart's lower chambers are resetting their electrical charge for the next beat. Notice exactly where it sits in relation to the ST segment and the QT interval. When we're evaluating that baseline, there are some pretty strict rules we have to follow. Normally, the T wave absolutely must be upright in all leads, with the standard exceptions of AVR and V1, of course. Amplitude is a massive clue too. It should be less than 5 millimeters in the limb leads and less than 10 millimeters in the precordial leads. Now keep in mind that upper limit for precordial leads does drop slightly to 8 millimeters for females. And its duration? That's intrinsically tied to the QT interval. Basically, anything outside these parameters is your cue to pay much closer attention. Moving into Part 2, T-wave abnormalities overview, the Rogues Gallery. Think of this as your clinical mental Rolodex of pathologies. A flattened or distorted T wave can take on so many different shapes, and it can indicate structural strain like left or right ventricular hypertrophy. It can also point to immediate, life-threatening conditions like a massive pulmonary embolism, genetic anomalies like hypertrophic cardiomyopathy, or even act as a massive warning sign for an impending anterior wall attack, which we see in Whelan syndrome. Part 3. Peaked and hyperacute variants. Let's look at some visual contrasts. What's really fascinating here is how sudden shape changes can mean completely different medical emergencies. Let's compare two distinct patterns. First, picture tall, narrow, and symmetrically peaked T waves. That symmetry right there, that is the classic hallmark of hyperkalaemia, dangerously high potassium. But contrast that with a second pattern, where the T waves are also tall, but they are broad and asymmetrically peaked. Those are hyperacute T waves. We see these in the extremely early stages of an ST elevation myocardial infarction, or STEMI, often before the actual ST elevation even shows up. You might also spot this broad shape with Prinzmetal angina. We also have to be constantly on the lookout for a loss of precordial T wave balance. Remember how we just said the normal T wave in V1 is usually inverted? Well, if you see an upright T wave in V1 that happens to be larger than the T wave in V6, you are looking at a type of hyperacute T wave. Finding an upright T wave in V1 is highly abnormal. It's especially concerning if it's tall, and even more so if it's newly developed. Make no mistake, this is a massive red flag strongly implying acute ischemia. Part 4. The inverted T wave. Contextual nuance. Now, going upside down isn't always a bad thing. Believe it or not, inverted T waves in the right precordial leads, so V1 through V3, are actually a perfectly normal finding in children. It just represents normal right ventricular dominance. Sometimes this even persists into adulthood. We call that a persistent juvenile T wave pattern, and it's actually most commonly seen in young Afro-Caribbean women. Also, an isolated T wave inversion just in lead 3, that's considered a completely normal variant too. Section 5. Myocardial ischemia and infarction, the clinical red flags. So the absolutely crucial point here is distinguishing between an active, ongoing event and the permanent scars of a past injury. Dynamic T-wave inversions, meaning they change over time or fluctuate with symptoms, are seen with acute myocardial ischemia. It means the event is happening right now. Conversely, fixed T-wave inversions that simply do not change are typically seen following an infarction. You'll usually see these fixed inversions permanently tattooed on the ECG, almost always sitting alongside pathological Q waves. Furthermore, it's really helpful to know that these ischemic inversions group together anatomically. They occur in contiguous leads based exactly on the location of the damage. For instance, inferior damage shows up in leads I, 3, and AVF, lateral damage in I, AVL, V5, and V6, and anterior damage will show inversions in leads V2 through V6. When you see deep inversions right alongside those Q waves, it's a clear indicator of a recent anterior myocardial infarction. Finally, Part 6, Bundle Branch Blocks, Expected Abnormalities. To really understand this one, we have to grasp the golden rule of appropriate discordance. This rule states that an abnormal depolarization, which is exactly what a bundle branch block is, must be followed by an abnormal repolarization. Because of this, the ST segment and the T-wave inversion will appear completely discordant, or opposite, to the main direction of the preceding QRS complex. So, in a bundle branch block, a T-wave inversion isn't just common. It's a fully expected finding, even without any ischemia present. Let's think about how this builds across different blocks. If we look at a left bundle branch block, following our discordance rule, we see the expected T-wave inversions in the lateral leads, I, AVL, and V5 through V6. Compare that to a right bundle branch block. In that case, the discordant T-wave inversions show up in the right precordial leads, meaning V1 through V3. It matches perfectly. As we wrap up this explainer, I want to leave you with one absolute, non-negotiable rule to really anchor your clinical practice. You can memorize all the variants, all the expected morphologies, but if you take away nothing else today, remember this. New T-wave inversion, when compared with prior ECGs, is always abnormal. So the next time you're holding an ECG, ask yourself this. You know what shape the T-wave is today, but what shape was it yesterday? Because if you can't answer that, what else are you missing? Keep looking close, keep comparing those strips, and we'll see you in the next explainer.